Paroxysmal Nocturnal Hemoglobinuria, PNH, is a rare acquired intracorpuscular defect. Its defining feature is heightened sensitivity of red cells to complement-mediated destruction, leading to intravascular hemolytic anemia, pancytopenia, and a striking predisposition to venous thrombosis. The classic symptom is hemoglobin-containing urine appearing first thing in the morning. The molecular cause is a somatic mutation in the PI gene, which cripples the synthesis of the GPI anchor, a molecular tether that holds protective surface proteins in place. The proteins lost include CD55, CD59, and C8 binding protein, all of which normally shield blood cells from complement attack. Diagnosis today is made by flow cytometry, which demonstrates reduced CD55 and CD59 on red cells, white cells, and platelets. The older Ham test acid serum test is now considered archaic. PNH results from acquired PIG gene mutations in hematopoietic stem cells, producing a clonal population deficient in GPI-anchored complement regulatory proteins, CD55, CD59 on red cells, leukocytes, and platelets. Presents variably with hemolytic anemia, episodic or chronic hemoglobinuria, thrombosis at atypical sites, example, hepatic, abdominal, cerebral veins, pain crises, erectile esophageal dysfunction, and possible marrow failure. Many patients also report fatigue and abdominal or back pain. Screening and diagnosis rely on flow cytometry for absence or decreased expression of GPI-anchored proteins, CD55, CD59 on blood cells. Labs typically show elevated LDH, low haptoglobin, increased reticulocytes, and sometimes iron deficiency. Thrombosis, especially hepatic Budd-Chiari syndrome and other unusual veins, chronic renal dysfunction, smooth muscle dystonias, and risk for progression to acute myeloid leukemia, AML, or myelodysplastic syndrome, MDS, in rare cases. Anti-complement therapy, eculizumab, rovulizumab, is first line for hemolysis and thrombosis prevention. Pegcetacoplan, C3 inhibitor, is available for inadequate C5 response. Supportive therapies include folic acid, and iron supplementation may be needed if deficient, but intravenous iron should generally be avoided due to possible complement activation. Transfusions as needed. Careful monitoring for thrombosis and cytopenias is essential. Bone marrow transplant is reserved for refractory or MDS/AML cases. Life expectancy is now near normal with anti-complement treatment. Ongoing clone size, cytopenias, and breakthrough thrombosis hemolysis require regular surveillance. Anticoagulation may be necessary for thrombosis, and women should avoid estrogen-containing contraceptives due to elevated VTE risk.